talking.
We keep talking.
Yeah.
Well, it's okay. Brian said we just missed everything that I said, which is a treat for you. You are in good hands.
I literally said all the smartest things I've ever said before, and no one heard it. Like,
Well,
gosh,
we
that
just
was-
gave you all the answers. Well, thanks for coming to the show.
Thanks for coming.
All right. If you missed all that and you weren't able to hear it,
Yeah.
the question is, I have nerve pain in my hand. Is it carpal tunnel? Thank you, Brian. Now people can hear us. So I have nerve pain in my hand. Is it carpal tunnel? That is the question for the day. All you missed was the banter of how amazing our bodies are and how many things that we could talk about from head to toe. There's so many different joints that we treat on the body. You know, we are spine-oriented, sport-oriented clinic, and they all jive together. So that's the gist of it there. Well, let's go into that question. Once again, I have nerve pain in the hand. Is it carpal tunnel? We've all had that sensation, that numbness, that tingling. Cade, what is carpal tunnel?
I'm excited to talk about this. Carpal tunnel, so it is that pain, it is that numbness and tingling in the hand. That's typically what you will feel. It typically comes more towards the thumb side because it's the median nerve that is being compressed here. And so what carpal tunnel is what's called a compressive neuropathy, meaning a nerve structure is being compressed within the carpal tunnel, okay? And so the carpal tunnel, what that means, you've got your radius, you've got your ulna of your forearm, and then you get into your hand bones, and in the middle, the wrist bones are called your carpal bones. Now they are smaller bones, right? That run across there here look like little nubs.
Yeah.
Love those bones, carpal bones. They have the ability to fan and fold and move and do whatever you need to do, which is why I'm able to do this kind of stuff within my hand, right? Now what they create is a little tunnel because they kind of dip down in the middle and create a tunnel, okay? There's this transverse longitudinal ligament that goes over the top of it, and through that tunnel runs a few structures. So there's 9 tendons, and then there's the median nerve. Those are the main structures that run through there. Now the median nerve supplies sensation to part of the thumb into the second and third finger over here. So that's where you'll typically get the majority of it, but also does quite a bit of with your strengthening, your coordination, your ability to grip and do things kind of with the dexterity of your hand. So this is what that is going to supply. And so typically, if you have a compression at that nerve, you will have lack of coordination, you will have weakness, you will have numbness and tingling in that region. And we typically see that with people that either do repetitive motions of the wrist. So we see that a lot. You've probably heard of this. A lot of people that work at a computer, so they're typing all day, receptionists, front office type people tend to get this type of thing. Or if you get into prolonged positions. So a lot of times we see this with like a painter or somebody who works in construction that gets in like a position for a long period of time doing something. And there are certain people that get into sleep positions that they might sleep like this. This is what's comfortable to them, but as you can see, you're really putting a lot of compression right here into that carpal tunnel, and so that can cause some issues. And so it may seem pretty cut and dry. There's a compression there, and we need to relieve that. And that's typically what happens that we see a lot of times is that, you know, you go into a doctor, you got some nerve irritation through here. They say, well, it must be the carpal tunnel, so we need to go relieve pressure. And so what do? They go in there, they cut it open, they relieve the pressure through surgery.
Yeah.
Now, that seems all well and good, but one thing that I would like to talk about is something that I've seen time and time again. In fact, I literally talked to somebody 2 days ago that I was treating that told me about getting carpal tunnel surgery because they had numbness and tingling in their hand for years, and guess what? It didn't relieve it.
Doom, doom, doom.
Doom, doom, doom. And this is actually something I hear quite a bit. And so by no means am I saying you should never get carpal tunnel surgery, but I want to talk about this for a second. So compressive neuropathies, let's talk about this for a second. The reason why you get a compressive neuropathy, the way that nerves function is that there is flow through the length of the nerve. So there are literally what they call synapses, okay? This is down on a cellular level that initiates in the brain, okay? So you can tell yourself to do a movement, the brain can reflexively make a movement, whatever it may be, and there's a flow of electrical energy that flows down synapses through the spinal, out of the brain, to the brain stem, into the spinal cord, into peripheral nerves, and then into the motor unit where it attaches into a muscle to create the movement. Now, that electrical flow of energy has to be maintained, and if it's not, then you're going to have issues, because anything past that compression, the flow isn't going to be able to get there, so you're going to run into weakness, tingling, all sorts of issues, right?
Yes.
The other part of that is that nerves are a tissue, okay? So all of our tissue in our body has to be supplied with blood flow, because blood flow brings in oxygen and it brings in nutrients to maintain healthy tissue. So it may not necessarily even be that there's compression directly on the nerve. It could be that there's compression somewhere in, you know, the vascular structures that are coming to supply blood flow. There's quite a few things that could potentially happen that could cause these symptoms, but that's the point. That's how it happens. Now the key here is that to have symptoms in your hand, I mentioned that anything past that compression is going to have the symptoms. Now here's the problem. You could have something up here that if there's a compression up here, it could cause symptoms down here. You could have compression here, and it could cause issues down here. You could have compression in several different places, and it could potentially cause the symptoms down here. And so Tyler, I think this is where it's good for you to step in here and kind of explain what we're meaning. And basically it's this: if you're having numbness and tingling in your hand, it is not automatically carpal tunnel. It could be, but it is absolutely not automatically that. And if you ever just automatically say, get diagnosed with carpal tunnel, let's go to do surgery, I would be weary of that, right? So help explain kind of why that would be.
No, very, very well said. Carpal tunnel, right? A test, we were looking at this, a very specific test to know if it's carpal tunnel is a shaking of the hand.
Yeah.
If I do this and I shake my hand and I stop, it's like, ooh, that relieves it. You kind of jostle the nerve in there and you get some relief into the hand.
Yeah. What do you think that does, by the way? It creates a pumping structure to bring fluid into the area.
It's bringing fluid here, blood flow. You go, it feels better into my hand. I think it's very interesting, right? In the PT world, we're always studying the nuances of this, right? That's why we specialize in outpatient orthopedics, because we got to spend our time studying that very thing, right? That will rule out what's going on or rule in. There's different tests, rule out or rule in what you have, right? Like you want to know before you leave a hospital, did I just have a cardiac arrest? Well, you better hope there's a test that's very, very specific to say yes. And if it's a no, you can move on with confidence, like carry on, you're okay.
For sure.
You're gonna wanna know that stuff. So that's why we study these tests for cervical spine, carpal tunnel. So Kate brings up that great point of where is it, right? I just picture a dammed up river, right? I was just up at Sun Valley and those beavers are creative little animals, right? so they build up that dam and the water gets stopped there and there's like a little trickle. It doesn't completely stop because the river keeps going, but that's what happens very similar in the body, right? Where is it getting dammed up? The electrical impulse. And your nerves need three things: blood, like Kate just said, space, and movement. Right? So blood, the nerve is a structure, so to stay alive and do well, it's got to have good blood flow going to that nerve. It's got to have space to move. If you have minimal space, like in the carpal tunnel, you're going to possibly feel that. And then it needs movement, right? It's got to have an ability to move. So how about someone who can't extend their wrist very well? Like what if they're just locked up into the joints of the wrist? Then now my nerve doesn't get the movement that it needs. So does surgery go repair the movement in my wrist? The answer would be no, right? If you've had that for years, you're like, yeah, I just can't, I've been in a cast, whatever happened, and I can't move my wrist, that's gonna affect how that nerve flows. So I've seen that happen a lot as well, where someone's like, man, I feel like I have carpal tunnel. Well, we start focusing on mobilizations here in the wrist, and now they're like, whoa, I can move my wrist, and now the numbness is gone. So that's why a nerve needs blood, space, movement. But back to the dam principle. I just want to say that word over and over. This is fun.
Yeah.
Trey, my son's like, what are you saying, Dad? You can't say that.
So my son's watching because he just said, good job. Thanks,
oh,
Jonah.
wow, Jonah,
Appreciate
you rock, man. So you have up here nerve structure. We talked a lot about this in the lumbar spine. Same thing goes for cervical. Here's your two vertebrae stacked on top of each other. You have a disc that lies in between, and on either side you have your nerves that are exiting, right? And they innervate different parts of the hand, meaning they give function of feeling, and they give motor control, meaning the contraction of muscles to those areas. So you have basically C3 through C7 running down into the hand, like Cade says. Very typical. If something's being pinched up here, you're going to feel it in specific spots on the hand, right? We're trained to do that. We're not going to get into that today. We won't bore you with that. But majority, what we're seeing in the research, majority of any symptom down into the hand is coming from the cervical spine.
Mm-hmm.
You'll see a rare occasion from the elbow, like cubital tunnel syndrome, right? Or ulnar entrapment, that's a nerve issue in the elbow that you'll see on occasion. But the least likely actually is carpal tunnel, believe it or not.
Yeah.
I would call it the piriformis of the upper body. So the piriformis runs through the buttocks. A lot of people say, ooh, I got piriformis syndrome that's shooting all the way down my leg into my foot. Yes, the piriformis muscle, it is a muscle, the piriformis, could cause that down into the foot, but it's less than 5%. Less than 5%. So the odds of having true piriformis, very, very rare. Very similar for carpal tunnel. More than 80% of the issues come from the cervical spine. So you're thinking, well, what does that mean? What's this word, radiculopathy? You're going to hear a lot of physicians say that. A cervical radiculopathy means, the pathology lies inside of the nerve. That's why it's opathy, right? There's an issue with the nerve. Radicular means it's radiating away from the source. So if the source is here, and I have radiating, right, radicular symptoms shooting down into the arm, that's called radiculopathy. It's coming away from the source. And there's a couple tests that we can do. I can come load Kate Anderson here. If I'm here, look up there, and I close down on this vertebrae here. If I close down on that nerve, this is what I'm doing right now. I'm closing down and I'm putting compression. If he's like, yeah, I feel that down into my elbow when I do that, you can rule out carpal tunnel instantly. And this is what I often see in one basic test. I just do this, load it, and he goes, yeah, boom, into my hand or into my elbow. Well, I'm not moving his hand. I'm not moving the elbow.
Yeah,
You know it's coming from up here. So there's specific tests we can do to say, where is this coming from? And so that is when the disc or whatever tissue, we don't know always what tissue it is. I don't want to get on this camera and be like, it's a disc that's pushing into your nerve. Whatever it is pushing into your nerve is a soft tissue structure, most likely, that can be moved. If it's not a soft tissue structure, meaning ligament, disc, muscle, those types of things, then it's going to be a hard structure, and that's where we hear the word stenosis. I had someone tell me this the other day. Stenosis just means narrowing. It's a narrowing of a hole. So if I have a hole here, and I narrow it, and I narrow it, and I narrow it, well, that nerve that runs through there is going to be pinched. That's a form of stenosis. It's a very widely used word in the world today. It's very misrepresented. So stenosis can have multiple meanings.
And even to have a severe enough stenosis to actually pinch is so rare.
So rare.
In all reality, what it does is it just makes less room for error. That's what I like to help people understand. It just means you got less room for error. So if you do when you got less room for error, you got poor posture, you got weakness, whatever it may be, you're doing repetitive motions, you just don't have that room for error that you did previously if you didn't have it. So it's not like this diagnosis where it's just like, sorry, you got stenosis, you're going to hurt the rest of your life.
So say we diagnose it here, 80-85% are going to be up from here, which you and I have seen, not just in the research, through clinical expertise, so many times. And you have to be careful which PT you're going to, because we've learned this time and time again. We just went to a recent course that reinforced this. We had an in-house course about the lumbar spine here at PT, and they talked all about giving the patient what they need, not what you can do. Well, I'm really good at carpal tunnel mobilizations, and I went to tons of courses and spent thousands of dollars, so I'm just going to always mobilize this. Well, what if this isn't the problem for Kate Anderson? I'm just giving you what I'm good at, or what I just paid a lot of money for. You got to give the patient what it is they need. You got to truly assess where is the root of the problem. Because if not, you're just hacking around, just trying to stop symptoms, and it can get messy in this arm when you're trying to just chase symptoms all around. So Cade, what do we do? When you've now diagnosed that it's up here in the cervical spine, what can PT do for that? So
what they show is that somewhere between 80 to 85% of neck pain is what's called mechanical in nature, meaning that it is affected by the movement, right? So you might have good days, you might have bad days, you might have days where it feels constant for a while. What that means is it's dependent on what you've been doing, right? So if you go to work and you sit at a computer and you are like this at your screen, which I do, I'll admit it, it's hard not to do that. that could potentially cause some issues. And so mechanical diagnosis and therapy is basically the ability to assess which motions or positions cause what's called peripheralization of the pain or the numbness and tingling, meaning it's radiating further. That radiculopathy is getting worse, so it's going further down the hand. And then which positions or movements centralize or reduce the radiculopathy and make it come up more towards the source, right?
Yes.
And so you have to be assessed by somebody that's trained in that. It's actually not easy at all. Sometimes you need to be in a loaded position where I'm weight bearing, so the spine is actually compressed more. Sometimes that's what's needed in order to affect the tissue that's the problem. And we don't know the tissue that's the problem. And by the way, neither does an MRI, but frankly, right? Because it's not going to go in and show to that level, right? But what you can know is you can just look at the symptoms that change as you do movement. That will tell you, even better than MRI would, what is going on and what needs to happen, right? And so you might need to be loaded, you might need to be in a supine position, laying down supported where there's not compression. There's a lot that goes into this, but the point is that you need either, if you find the position or the movement that centralizes your symptoms, what that means is that one of three things are happening, right? It's like you talked about. Either that creates more blood flow to the area, that creates more space, right? Or it creates movement to the specific tissue. Just like you talked about, those are the three things the nerve need. And so it doesn't really matter what it is. The point is we're looking for what did it, right? And so we will oftentimes find, and it might be that it's repeated retractions, repeating them over and over and over again, that creates space, fluid, or movement to the structure that's causing the issue. And we'll know because it centralizes, it will return to the source. And once it returns to the source, we're able to treat the source and then improve it, right?
And you need a skilled PT who knows mechanical therapy, who knows how far to load it, how long to load it, how many repetitions, what's the response you should be receiving, what's a red light, meaning don't do any more. What's a green light, like push it harder. What's a yellow light that's like, we're coming to the intersection here, you better have your foot ready on the brake, right? Like that's what a mechanical therapist will do. So the drive home message here, holy cow, we get passionate and it's fun. The drive home message here is I have nerve pain in my hand, is it carpal tunnel? Most likely not. I hope you're hearing that. Most likely not. I'm not saying it's not a possibility, but you need a skilled therapist who's going to assess it properly and not just give you what they're good at or what they just took a course on. They're going to give you what it is that you need to know and address where the true root of this these numb nerve symptoms are coming from, or else you're just going to chase around. So you need a skilled physical therapist to find where that's at. It's most likely coming from the neck.
And I think my take home would be this. If you have symptoms here and you go to a doctor or anybody and they say, clearly carpal tunnel, let's do surgery, never do that surgery until you have been assessed by somebody that understands what we just talked about. Make sure to clear the neck. And I'm going to tell you this, an MRI and an X-ray will not clear the neck. You need to have somebody that knows how to truly assess the movements and what's going on and understands the way the nerves work to truly look at that, give some treatment, and see. You'll be able to tell, honestly, within 1 to 2 weeks probably, of going to a physical therapist, if it's that or not, right? It's not one of those things where you'll be there for 10 weeks, like 1 to 2 weeks, you will be able to know if that is it or not, and if it's going to get better. Then you can feel confident going and saying, okay, I need the carpal tunnel release. Because guess what? There are times it's needed, and there are times that that's what fixes it. You just don't just rely on that. Make sure that the neck is truly cleared before you just go have a surgery. Because I've just seen time and time again, people get carpal tunnel surgery, and guess what? That wasn't the problem, so they still got it. So
wow, I love giving this. This is why we get so passionate, because we've seen so many people struggle with this and make the wrong decision. There's so many decisions that you can make. I get it. There's like a sea of endless opinions that are out there. I get it. We could appear to be another opinion, but trust me, what he just said there is a huge nugget. The X-ray or the MRI will not clear the neck, meaning it's not going to find the problem. Do you know, little teaser in an upcoming Facebook Live, to find something that is normal on an MRI? If Kate Anderson went in right now, young, strapping young man,
really
went in
strong.
right now, really strong, buff neck. But if he went in right now for an MRI, it would be considered abnormal to find a normal MRI. Like to not find something that's like, oh, you got some disc degeneration, or oh, you got a nerve entrapment, or some narrowing over here. It would be abnormal to find a normal reading on his MRI, meaning the MRI cannot just be your source of like, ooh, it's not in my neck. Trust me.
Yeah.
So if you have questions, ryanpt.com, contact one of our doctors of physical therapy, get in for a consultation or an evaluation, and find out where is this source of pain in your arm. Trust me, you won't be disappointed.
Perfect.
Thanks.
Thanks, guys.